Welcome to the DocTalks Podcast. I'm your host, Mandy Fields. I'm here to ask medical experts the questions you might have about diseases and conditions, from heart health to dementia and everything in between. Join me for a conversation where we get right to the points you need to know to navigate Canadian medicine and hospital healthcare. Hello and welcome back to Doc Talks. I'm here with Dr. Suskin. Dr. Suskin is the medical director of the Cardiac Rehabilitation and Secondary Prevention Program at St. Joseph's, a Lawson Research Institute scientist, and a professor of medicine, epidemiology, and biostatistics at Western University. Dr. Suskin is known for his outstanding leadership in creating and disseminating knowledge focused on cardiovascular chronic disease management and for establishing pragmatic, evidence-based cardiac rehabilitation systems. He led the 25-site Ontario Cardiac Rehabilitation Pilot Project, which demonstrated the effectiveness of province-wide standardized deployment of CR interventions using integrated data management systems with regular audit and feedback. This pilot led to the establishment of what is now St. Joseph's Cardiac Rehabilitation Program. So thank you for joining us. It's really impressive. And I wondered, just to start off, can you explain in a way that our listeners can understand, like what exactly happens at the St. Joseph's Cardiac Rehabilitation Program?
Sure. So after someone experiences a cardiac event, such as a heart attack, and that's when, somewhat without warning, someone may get chest pain due to one of the arteries that supply oxygen to the heart muscle blocking. And they would get admitted to hospital. They would more than likely get a procedure done to open that artery or arteries up through a stent-based procedure or surgery, bypass surgery. There's other conditions that would come into play, but let's stick with those. That patient's in hospital for a few days. A lot of things happen to the patient. It's confusing. And when they leave hospital, they get a referral to our cardiac rehab program, which is based at St. Joe's. They would have been in hospital at the London Health Sciences Centre, more than likely at University Hospital. They get a opportunity while they're in hospital to scan a QR code that's available to them in the ward that explains the rehab program to them, so that they're leave with the notion that they will be contacted. They have follow-up planned. And when they come to the rehab program at St. Joe's, which will hopefully be a few weeks later, they get assessed by a team, cardiologist, a nurse, and they review their condition with the patient, and they set a plan for healthy lifestyle changes to be taken up to prevent the future event. And that assessment that happens establishes which risk factors, like blood pressure or cholesterol, need to be managed more aggressively with more medications if necessary. Those get prescribed at that first visit. The patient gets an exercise test scheduled where we can see how well they can exercise, what their limits are, and where their training range would be. Think of having a personal trainer at a gym. We don't quite do that, but they come back in for the exercise test, which is run by a cardiologist with technologists. We see how fit someone is. We measure their consumption of oxygen with a little mouthpiece in their mouth to measure their peak VO2 or oxygen consumption. Then the exercise trainers meet with them subsequently and derive a exercise prescription or program for them. They teach them how to use equipment, and then patients, we don't have our own training gym anymore. That ended with COVID, but patients are able to train wherever they choose, in their home, walking, or at a gym, using the prescription that our trainers provide them. And then our trainers check in with them every few weeks by phone or video or in person to make sure that they're adhering to prescription, have any of their questions addressed. And this carries on for about 5 months. And then we start wrapping up their program with an exit series of encounters to check their risk factors again, have them see the nurse again, and do another exercise test and get a prescription for going forward. I described the exercise component, but concurrent with that, patients can avail themselves, and it's strongly recommended, to meet with our dietitian, if needed to meet with our social worker and or psychology services to support them through the program to make sure that their concerns, fears, anxieties are addressed after the cardiac event. So to wrap up, it's in general, a 6-month program with a standard set of assessment processes that take place and a standard set of interventions that take place over the course of 6 months to get someone back to being as good, if not better shape than they were before the event.
Wow, it's like a all-in-one system. That's what it sounds like. I've had this burning question since looking at the notes provided to me from Emily and the team at St. Joseph's. My question, Dr. Suskin, is why the heart? How old were you when you wanted to study the heart, become a heart doctor? I'm just really curious, like how you are who you are. And I think our listeners would want to know that. Like, how are you wired the way you are?
Well, and this is for a general audience. I'm not Canadian originally, as you can tell. So I'm from South Africa, but I was always interested. So I did my medical school in South Africa at the University of Cape Town. And I don't know if you're aware of that, but that was where the first heart transplant in the world took place back in the late 60s, Dr. Barnard. So maybe this, we were clear when I went to the University of Cape Town, they remind you of that sort of all the time. So maybe there was some interest from that side of things. I was always interested I did competitive sports when I was a student. So I was interested in somehow combining sports with whatever I did in medicine. When we came to Canada, right after we did internship in those days, I was just a very new general physician. And as part of the process to stay in Canada, you have to integrate yourself into the Canadian system. And so almost by chance, I got an internal medicine residency spot in St. John's. We were in Newfoundland. And I had wanted to do sports medicine, but that fell through. So I ended up in internal medicine, which is a very broad field. If you think of rheumatology and respirology and kidney disease and blood pressure management, that's all encompassed in internal medicine. So because of I found that very complex, and because of my interest in sports and activity, I gravitated towards cardiac rehab. And that meant I had to do cardiology. So my wife and I, she's also a physician, she navigated the system a little easier. It was always easier for her to get, residency spots and further opportunities. She was a better student than I was. We relocated to London, and that's where I got a spot in cardiology residency after internal medicine. And then I did my subspecialty training in cardiac rehab in McMaster and came back to London to start the program in the late 90s. So that's sort of a long-winded version, but it was largely an interest in activity and sports, finding internal medicine too complex, and finding cardiology as a good area where I could take forward the combined interest.
Thank you for that. Can you share with us signs of heart disease?
Certainly. So there's, a variety of heart disease types, but the one that we're largely talking of now will be the condition that's related to plaque buildup in the arteries, or atherosclerotic heart disease. So that would lead to a heart attack. So signs of that would be generally if someone were being active, they could start to notice some limitation to their activity based on feeling chest discomfort or chest pressure, or feeling discomfort in their shoulders or jaw, or just generally feeling unwell with activity that would generally be reproducible with a similar kind of level of activity. Or it might come on after eating a meal where blood flow tends to have to support other organs, and so your heart may get proportionally less flow, although it tends to get the most. And then you might get those symptoms that would be related to a gradual narrowing of one of the arteries around the heart. Now, if that plaque buildup inside the arteries are not very big, they're smaller than your fingers, so to speak. If you get plaque buildup on the artery wall, then for reasons we somewhat understand, but not fully, that plaque lining can crack. The blood vessel tries to heal itself and blood cells stick to it and block the artery. That's a heart attack. So that can happen at any time. And you would feel that same kind of chest pressure and pain character as you might have experienced walking or running, but it would be more severe. It may be associated with sweating, feeling very unwell, then it doesn't go away in 5 or 10 minutes. So that would be when the artery is blocked. You would need to get to hospital by calling emergency services, not driving yourself. And then the procedure would start in terms of finding out what you had when you got to hospital and trying to open the artery as quickly as possible.
Thank you. It does. It feels like it's like a ticking time bomb. My husband right now, last week, he was wearing a heart monitor, and
Right.
there's lots of fear and, that we're just kind of wondering, waiting for the results. But hearing you talk about, the plaque buildup, there's so much about the heart where I think that I personally have taken for granted until this moment with my husband. To be honest, you hear about it. I am curious, though, about why are men more likely to experience a heart attack and develop heart disease earlier in life than women?
Well, the women generally have hormonal balance is protective in women before menopause, with the estrogen predominance. And that would be a physiologic lower risk that women enjoy over men. And they, as you correctly state, they would tend to get it about 10 years before men. But, after menopause, it's an equal opportunity illness, so to speak. The incidence, which means the number of new cases or new events, goes up for women, and they probably never catch up with men. But if they live 10 years longer, then, eventually they'll be having the people that are living, you may have more women than men having events just because they're older, if you follow, and the younger men may no longer be alive. So that's one of the reasons. However, if you're not doing much activity, if you smoke, overweight, and with diabetes, then that sort of negates the benefits of being a woman. Obviously, it increases the risk for men too, but it increases your chance of having heart disease because the plaque buildup is accelerated. That's what we're really talking about. What are the conditions that will lead to faster plaque buildup?
So you said smoking. So I'm trying to figure out what are the biggest risk factors.
So certainly there's the non-reversible risk factors, so if you have a family history of someone having heart attacks or stroke at a younger age, sort of before 50, we would say it's a little different in men and women, and you're that person's child or sibling, that puts you at higher risk. The risk doesn't go further than that, not grandparents or anything like that. So immediate relatives, that gives you a sort of a inherited risk that's higher than usual. If you're sedentary, not doing your 150 minutes of activity a week, etc., or your 5 or 10,000 steps, that increases your risk of, plaque buildup. If you smoke, that's no matter what you smoke, but obviously historically it's been tobacco, that increases your risk. And if your cholesterol is elevated, that increases your risk. If you have diabetes, if you have high blood pressure. So all of those risks combined, some of them are more powerful than others, lead to more plaque buildup and a more unhappy plaque. So in other words, if two people have the same amount of plaque and the one person stops smoking and gets their cholesterol treated and becomes more active, they can both have the same amount of plaque 6 months later, but the person who's made those healthy choices, the plaque is going to behave better and it's probably not going to crack. And so they may never know they have it, if you follow.
I do follow. I'm picturing myself in my husband's cigar lounge that he had to have, and how he tells me that cigar smoke's different than tobacco smoke. Is that true?
No, I mean, really, there may be some subtle differences, but, the smoking is a risk factor, more than any amount is bad, but, more than 10 cigarettes a day is particularly bad. And the toxins that are inhaled, not necessarily nicotine, that's the addictive part, but everything else that's part of a cigarette is really bad for the lining on the inside of your arteries. And that leads to plaque formation.
Definitely be sharing this with him tonight. Is there any research or evidence that would suggest that vaping and e-cigarettes are just as harmful as regular cigarettes?
I mean, it's an expanding, emerging field. So the answer is that it's not good. Okay, that's clear. Now, in Canada, the companies that produce these agents obviously want to sell more of them, and they're not supposed to be made appealing to the youth, but they are. So the agents and the oils that are involved with vaping are dangerous to your lungs and dangerous to your heart, and especially if they contain any nicotine to some degree to make them, more addictive, these agents are not safe. I don't think any research has shown. It's not quite my area. I mean, we do use, in fact, we're part of a trial that I'm one of the investigators in out of Montreal, but We do use e-cigarettes to help people quit smoking. So, coming off a cigarette product to a controlled use of an e-cigarette has been shown to, we think, benefit smoking cessation. And we're doing a trial now looking at that in patients with heart disease. So the short answer is, I don't think there's any evidence to say that the vaping is harmless. And there's emerging evidence to say that it's harmful, especially if it leads to any smoking behavior or any form of tobacco use going forward.
So what can people do to prevent heart disease? I mean, it sounds a little rhetorical based on what we just said, but do you have a couple of easy tips that our listeners can hold on to?
Yeah, certainly. I mean, I think making massive changes is very difficult, right? So some of my patients, when we encourage them to adopt a very heart healthy diet, which is often a Mediterranean diet, a low fat diet, would tell me, even if I don't live longer, what you're making, quote unquote, making me do is making me feel like I'm going to living longer, if you know what I mean, because they're not happy. So we don't want that. So make small changes and stick with them. So try and increase your physical activity. If you're not active, to being somewhat active. I'm not saying immediately start running as hard as you can, because that has dangers associated with it, and we can talk about that. Increase your physical activity by walking more. If you can find 5 or 10 minutes a day just to go for a walk, and you weren't doing that before, that's beneficial. So that's the one part. Get help from your physician to quit smoking if you smoke. That's probably the biggest reversible risk factor. And whatever you're smoking, it's not good, including, marijuana is legal now, but I mean, that's not good for your heart in any shape or form by whatever means you take it, but it could be worse smoking it. And then check with your doctor to see whether or not, you need medication to decrease your cholesterol. That's very important. There's many agents out there that are useful. Adopt a heart-healthy diet, and you can get information from the Heart and Stroke Dietitians Ontario on the web. And again, make small changes that you can maintain, and just common sense goes a long way. So if you need to reduce, saturated fat in your diet from red meat, for example, not necessarily stopping it altogether, but, smaller portions or taking it less often, small changes that you can maintain. It's a behavior change. That's the key to what we do in cardiac rehab.
Thank you for that. What exactly does the cardiac rehab program at St. Joseph's offer? And is there any new and exciting research on the horizon?
So we offer what we call comprehensive secondary prevention. So primary prevention means, in broad terms, strategies to reduce your first cardiac or cardiovascular or cerebrovascular event like stroke. But once you had an event or been diagnosed with a condition, then we call it secondary prevention. It doesn't mean it's less important. It means that you've already had an event and we're trying to prevent the second event, because the people that are at highest risk for an event are people that have had one. It's a comprehensive program to reduce your risk by optimizing lifestyle behaviors and medications that you need to reduce a second cardiac event. And the new research that we're doing currently, we've done a lot of different kinds of research. We've looked at people that have experienced many strokes, putting them through a cardiac rehab program, and they do very well. And we've looked at cardiac rehab for other conditions like atrial fibrillation, which we haven't spoken about, a rhythm problem of the top chambers of the heart. And people do very well with cardiac rehab programs like that as well. But the current research we're looking at is really looking at how we prescribe exercise. So if you have people that go through a cardiac rehab program like ours, and we've published on this, we've shown that if you take a group of people that go through the 6-month program and compare them to a similar group of people that couldn't do it because they maybe lived, not in the London region, and look at their outcomes 10 years later, the people that went through cardiac rehab reduced their risk of dying or being readmitted to hospital by 50%. That's a very big reduction. So cardiac rehab does work.
Is there anything you want us to know that you wish that people knew, that you just wish we understood? Like if you could share your knowledge with the world and just say, if all of you would just listen to this one thing, I might be able to save a few more heart attacks.
I think people react way better to having their concerns addressed and becoming more knowledgeable and wanting to change behavior. No one reacts to be told to do something. So I would say look at accepted sources for good information. So the Heart and Stroke Foundation of Canada or Health Canada, use those resources to find out about heart disease and what you can do about it. there's some very good resources from those sites, and it gives you some idea about what to do to improve your health. But as we've discussed, the key things would be improving your risk factors, things you can do to speak to your doctor to help you quit smoking. There's many strategies and medications to use to help you quit. Speak to your doctor about your risk profile in terms of if you need anything more than lifestyle changes to address cholesterol, etc. The rules change depending on your risk. So depending on what your cholesterol is, someone might have said that's normal for you, but it may not be when they take into account your other risk factors, and your doctor can do that. And be more active. So, do more activity. That would probably be the biggest reduction in your chance of getting a future event.
Dr. Suskin, before we close, do you have anything else you want to add?
I think we've covered a broad range of atherosclerotic heart disease. We haven't touched on the other parts of heart disease, but that's a lot more detail. For example, atrial fibrillation, you might have heard of that, have you?
Mm-hmm.
The top chamber of your heart sort of races, and that's a growing epidemic. People are heavier and less healthy than they were, and the new case incidence or occurrence goes up with those risk factors, and that's a condition that makes you feel very unwell with palpitations, and it can lead to stroke because of little blood clots forming in the top chamber of the heart. So that's another condition that can be well addressed with lifestyle changes, as we've just described. That'll be the other main condition that probably worth mentioning.
I've seen an increase of AEDs being available in schools and sports centers. Is that because of the increase in what you just spoke about there?
Well, no. Well, the AED, the automated external defibrillator, is mainly for when some individuals, when they're experiencing a heart attack, the artery blocks and the blood flow to a large area of heart muscles is stopped. That heart muscle can behave very badly with respect to electrical impulses, and it may conduct them in such a way to set up very fast heart rhythms, because heart muscle tissue conducts electricity. And if it's not getting enough blood, it can be chaotic, and you can get something called ventricular fibrillation. And that's when the bottom pumping chambers of the heart go very quickly, 300 beats a minute or something, and that produces no cardiac output. So you just collapse. And defibrillators shock your heart back into a normal rhythm. So that's why they're around, and they can save lives. Having them deployed more widely is very important. Anyone can attach them, push the button and stand back. And if someone has a rhythm that would benefit from being defibrillated, then the machine will do it. And it can save lives before emergency medical personnel gets in. That's probably the one intervention that can make a real difference.
Well, thank you for joining us today, to our listeners, and to you, Dr. Suskin.
Thank you.
That's it for this episode of the DocTalks Podcast. Thanks for listening, and join us next time when we'll continue our conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. Join us for our next episode of DocTalks, and be sure to follow us on Facebook, Instagram, and LinkedIn. Until then, stay healthy.